Welcome to the Power Hour, Optometry's biggest and longest running show. I'm your host, Eugene Shatsman, and we've got an incredible episode for you today. My guest today is Dr. Sage Hyder. He's a clinician. He's been practicing in the same location for 30 years plus. He's been building deep, lifelong relationships with his patients, but he's also been staying ahead of the curve when it comes to medical optometry and technology. So that's exactly what we're diving into today. How do you make technology work for your practice? And Dr. Hyder isn't just bringing in his latest tools because they're shiny. He's definitely a numbers guy. And you're going to hear his formula and how he breaks down exactly how to decide which tech is worth investing in and what's not. He'll help you justify the ROI and how to make sure that every single piece of equipment in your office isn't just sitting there, it's actually earning money for you, just like another associate would. We'll talk about the must-have technologies that every modern practice should be using, the nice-to-haves that might make a big impact if you use them correctly, and some of the bigger mistakes that doctors make when buying equipment so that you can avoid them. And here's the kicker. Dr. Hyder's secret weapon isn't just the equipment. It's actually how he explains the procedures and the technology to the patients. So if you've ever struggled getting patients to say yes to diagnostics or treatments, you need to hear about his approach about communicating value in the exam room. So before we jump in, here's a quick reminder. Make sure you're subscribed on YouTube, Spotify, Apple, or wherever you get your podcasts. And if you have questions, feedback, episode ideas, go ahead and reach out to me directly at eugeneshatsman.com or on the Power Hour website. Now, let's go to the show. All right, Dr. Sage Hyder, welcome to the Power Hour. Excited to have you on the show.
Thank you very much, Eugene.
Yeah, so I think in order to make sure we properly frame up our conversation about technology today, I'd like you to give a little bit of background on yourself and your practice, because I think it's really going to help people understand the context with which you're contributing today, and also the context with which you get to see the world through on a regular basis.
Thank you. I've been very blessed with how I've been able to practice optometry. The things that we learned in school, I've been able to use those every single day in my practice. I live in a small town in San Luis Obispo, California. I've been in practice here in the same location for 30 years. And because of that, have had the ability to really see patients for quite a long time. I recently gave a lecture on glaucoma, and the speaker before me, a professor at one of the universities, was talking about how to treat glaucoma, and one of the participants asked him, "Well, what happened to that patient?" And he said, "Well, you know what? You have to understand that I'm in a certain setting that I might see a patient for 2 or 3 years, and then their insurance changes, they move to a different location, another doctor in the practice gets them, and I don't get to follow those. I've been treating the same patients for 30 years, and the first patient I gave my presentation after that was a patient I've been actually treating for glaucoma for 20 years. And
Wow.
So because of that, it has given me some ability to really get to know my patients well. I think my patients are more friends than they are really somebody that I don't have a connection with, whether their kids played soccer with my kids, or whether we're in Boy Scouts together, or on the community board for youth facilities. Those are things that we get to know each other very well with. So 30 years in the same practice, because we are in
And your practice is pretty high medical.
Yes, that's just about says. Yeah. So because 30 years in the same location, our small town doesn't have a lot of big HMOs. We don't have a big Kaiser hospital next door, or a big medical facility that we have to refer all of the patients over to that come in. And so because of that, we treat, like I said, everything that comes in the door. We were joking earlier that every Friday I get to remove a metallic foreign body out of someone's eye. It's the same story every week, that Tuesday they got something in their eye, they were grinding on a lawnmower blade, or actually the last 4 seemed like they've been working on their trailers, so welding and grinding on a trailer. Gets in there on Tuesday, they're miserable. They say, "Gosh, it was so bad, I couldn't even sleep Tuesday night." And so I said, "Well, why didn't you come in Wednesday?" And, "Well, I thought it would work its way out." And so Wednesday night, "Gosh, it was so bad, I couldn't even sleep all night long." Thursday, and I said, "Well, why didn't you come in Thursday?" "Well, I thought it'd work its way out." So then, of course, they're in my office Friday afternoon, and I'm digging something out. There's a lot of rust, putting bandage contacts on, have to come in on a Saturday to see them or something like that. It's just, so every kind of Friday I have that kind of fun
I
routine. I know it's going to happen.
I can only imagine that the reason. Well, why'd you come in today? Well, you know what, my wife made me.
Yeah. No, they usually don't want to let it go for the weekend. After 3 days of being
Yeah.
miserable, they don't want to let it go for the weekend. So, and so you talk about, what do I do? A lot of specialty. Like I said, we're an optometry practice that sees whatever walks in the door. I do treat a lot of glaucoma.
Hmm.
We're going to talk a little bit about technology today. We were the first office in the entire county, OMD or MD or OD, that had some kind of imaging device at the back of the eye. We had the original HRT, Heidelberg Retinal Topographer, back in 2001, and we actually received ours a week before the glaucoma specialist used it. Um,
Wow.
Being in a practice that has 3 doctors, I've had 3 partners my whole career. I've retired 2 partners, 2 younger partners have come in. We can afford to have a piece of equipment like that because we can split that between the 3 of us, and that's part of what we do. But we're going to talk a little bit about how to make that happen just in a single office and what that looks like. So, we talk about technology. I'm not a technophile. I'll tell you that right now. I have a 1965 Mustang. I'd rather drive that than some newer car. I do have an electric car, a Chevy Bolt, so wired up my electrical outlet in my car, or my garage, so I can charge that up in there.
Nice.
But I don't have Wi-Fi connected lighting. I don't have surround sound speakers everywhere. I don't have. I'd like to, but it's just not something I do. I can walk over, turn on a switch, turn off the switch, and so I like
But
that kind of
that
thing.
does actually bring, from a practice standpoint, that kind of brings things into perspective because you see a lot of patients. You probably got a lot of your technology out of need, and I've heard you talk a little bit about how you use. And one of the things that prompted the episode is the ability to intelligently justify whether or not your office needs technology or is ready for a piece of technology. And really, that's kind of what you were just getting at, is that, what's the difference between something that you really need and something that is kind of a, it's an okay, nice to have type of thing. And, how do you even start by going through those decision making processes?
Yeah, that's interesting because, like I said, I'm not a big technophile, but I do like technology that improves patient care. It improves patient care. It improves the ability to treat them. And it makes the flow in the office work very well. So having some technology, I think, is very, very important. Now, what is essential and what is not essential, you have to justify that for yourself. You got to think about how it's going to cost you. Can you afford to do technology? Can you afford new instruments? There's always a way to do that, and we're going to talk about that a little bit more. But just taking something, as simple as a fundus photograph. When I first moved into the practice here in 1994, we had a Polaroid Canon camera that could sit a patient down, get them. It was a supposedly non-mydriatic, but usually had to dilate them to get a good image in there. You took little Polaroids, you put the film in, you pulled the film back out, you waited for it to expose and see if you actually got a good image of what you were looking at. And that worked. That was 1994 we had that technology. It was getting more and more difficult to get the film. As you know, they stopped making Polaroid film
Yep.
for quite a while. So we couldn't get films. So, in 2005, got my first digital camera. It was amazing. It was an OptoView retinal camera. It could align itself, take photos. You had them digitally right there. You could upload them into your computer and into your software. They would have the ability to do collages, 3D, stereoscopic photos. Really kind of neat technology. And then, of course, we move on to things like wide field imaging. I don't know anybody who's practicing nowadays that does not have some kind of wide field imaging camera, whether it's an Optomap or a Zeiss or whatever's out there. It seems like everybody I talk to has one. Now, they're expensive. And, just getting a camera like that, you kind of have to think of how you kind of make that work. So when you ask me, how do I justify getting a piece of equipment, is it good for patient care? Is it financially going to be successful? And then when I evaluate some type of equipment, I always have things in my mind. Ease of use. Ease of use, I think, is one of the most important things. Is it easy for the staff to be able to get a good picture? If you have a camera that you can't get a good picture of, it's worthless. I can't get data that I can use. So staff has to be able to use it. So ease of use for staff, ease of use for the patient. If something's difficult for a patient to use, it's not going to be successful. Patients don't like doing the instruments. They complain about them all the time. They don't want to do a second one if you need to get some other data or repeat it in the future. So ease of use is very, very important. And then, like I said, good data. If you don't get a good image, you don't have good data. And you don't have good data, you don't have good treatment in that. And so evaluating any piece of equipment, that's what I kind of think about is what data is it going to give me and how easy it for the patients and the staff to use that. So, OptiMap comes around. They have these big, gigantic, old, original first generation OptiMaps that took up a whole room. I had looked at those that, geez, this doesn't make sense. They're very expensive. What kind of patients are going to really go for that? As things got smaller and technology got better, I invested in my first Daytona. So I've got a Daytona OptiMap. We got that in about 2014. And that's an expensive piece of equipment. You're looking at probably about $100,000 for back then was pretty expensive. And how do you make $100,000 piece of equipment work for you? So, we were talking earlier about kind of looking at the numbers here. You want to go through some numbers here?
Yeah, let's do it.
Okay. So if you get a $100,000 piece of equipment right now, we looked at loans, a 5-year loan on that at 6%. You can get a 6% loan from one of the good lending sources like Vision One Credit Union or through one of the other local banks. I kind of check some things out like that. $100,000, 6% interest, 5 years, going to be a payment of $2,000 a month. Okay. $2,000 a month sounds like a lot, So if you're doing $2,000 a month, each patient's going to pay you about $40 if you're doing this as a screening. Okay, if you're using it as a medical device, you're going to get probably about the same thing through Medicare, Blue Cross, Blue Shield. So you're going to probably get around $35 to $40 per image that you're going to do on that, which means you need to see about 50 patients in order to pay for that piece of equipment. So in my office, I see 13 patients. I see about 20 patients a day, 21 patients a day. 13 are usually at full exams. Full exam is going to be either a VSP exam, a Medicare exam, or something like that. It's not an office call, not a retinal check or something like that. So just my exams that I see, 13 a day. And we have a capture rate for fundus photos or a screening photo of about 80%. So actually we're closer to about 90% now. Patients really, really like this technology. So if you're 80%, you're doing pretty good on that. That means you're seeing 10 patients a day that you're getting an image out of. Okay. So 10 patients a day, they're paying you about $40 for that. You have to see 50 patients in order to pay off that loan. So if you're doing 10 days or 10 patients a day, that's 5 days of seeing patients. That's one doctor, 5 days of seeing a patient to pay for that. Now, I only work 4 days a week, so that's 5 days. I work 16 days a month. So the first 5 days go right into paying for the piece of equipment. Then I've got 11 days of now that paying me. Now, you have to think about that. You're going to have to hire some staff. And whether your staff can utilize your current staff or if you have to hire more staff for that, a staff is going to cost you, 35,000, 37,000, 40,000, depending on where you are. But that staff's going to be able to do multiple things on that. So if I'm seeing my 11 doctor days of just profit on that, doing that over the years, so that's $44,000 or $4,400 per month that I'm getting profit on that. You look at that over years, $53,000 in profit for having a piece of equipment is already paid off in those first 5 days.
Yep.
So,
and what's interesting is that if the lifespan of that thing is a little bit longer than the 5 years that you've projected here, then the profit number becomes even bigger in the 6th, 7th, and 8th year, right?
That is exactly right. Then you're getting all profit on that. And like I said, even if you had to hire a full-time staff in order to do this for you at $37,000, you're still making $16,000 a year just by having this piece of equipment in there. Now, it's going to be more than that, like you said. I've had my OptoMap since 2014, so I've had it for 11 years. It's still running well. They keep coming in telling me that I have to upgrade it because it's outdated and it's going to break down, and I'm going to have to do that someday. But right now, that thing is
going to drive that thing right into the ground.
Just making profit and being very, very reasonable to do that. So Like I
Well,
said, I don't know
and
anybody who doesn't have that technology in their office right now.
and what's interesting is that, you mentioned staff, but that staff person isn't fully allocated to that one piece of technology
Right.
because of the ease of use. Now and we'll talk about other pieces of technology and maybe run the numbers on them as well. But I did want to ask, you mentioned you guys have a really high capture rate on fundus photos. What's a tip or a secret, or what do you guys do in order to make sure that capture rate is somewhere between 80 and 100%?
It's pretty interesting. I tell you the truth, fundus photo has been the best practice management tool that I've actually had. When I can show it to a patient, and I can pull up an image from 2014 and an image today and do that comparison, patients are astounded by that. I talk through my patients everything that I do. I tell my patients, if you're going to see me, you're going to put up with my philosophies. My philosophies are, I believe patients are intelligent enough to understand what I'm telling them. They have a different education than me. I have a different education than them. They know things I don't know. I know things they don't know. But I think my patients are intelligent enough to understand what I'm telling them. So I tell them a lot. I pull up a fundus photo. I say, look, this is the optic nerve that plugs directly into your brain. It's got 1.1 million nerve fibers going directly from your eye to your brain. Now, here's what I'm looking at. I'm looking at the shape of this. I'm looking at the color, the contour. This looks very good. Here's an artery bringing blood in. Here's a vein bringing blood back out. If you're a diabetic, we're looking for aneurysms on the tips of the vessels. We're looking for hemorrhages. I show them the thickness of the arteries in the older people, saying, yep, your arteries are starting to get a little bit narrow. How's your blood pressure doing? You've been taking your meds. You talk them through what you're seeing. Here's the macula. This is where macular degeneration occurs. Oh, yeah, my mom had macular degeneration. Well, let's look at this. We have an autofluorescent image. Nothing's showing up on there. It looks nice and smooth today. And being able to compare that year to year, patients love that. So once a patient's done it, they always do it again. It's one of those things that go, should I do that every other year? I'm like, you go to the dentist every year, you get an x-ray every year, you're going to wait 2 years to see if something happened wrong. It's like, okay, that kind of makes sense on there. So I think that's what, the first year, no, we were 50% capture rate on that, got up to 60, 70, 70. We're really right about 90% right now in our practice. Because you utilize the tool properly, you teach the patient, as you're training the patient there, you give them the information. Why would they not want that? You look at something and go, hey, let's look at this little spot right here. You have a little hole, an old tear, an old scar. Let's look at that 5 years ago. You have a nevus. Let's see if that thing's growing at all. We talked about this has a potential, very low potential of, converting into melanoma because of the size of it. It's got drusen on the top of it. And you can look at those things over the years. They love it. They love that technology just as much as I do on there. I'm kind of passionate about that because
no, that's awesome.
I think it gives better patient care.
And I bet it makes patients come back more often because, I don't want to skip my exam because it's not just that my prescription didn't change.
Yeah.
It's that I got to get that scan and see if the stuff I can't see is changing on me.
Exactly. I have patients all the time. I don't understand this. They always come and say, gosh, this is the best exam I've ever had. I know my colleagues are doing a really good job. I know that the same education as me. They're doing the same quality care as me. They just don't tell a patient what they're doing. And so, when you're doing, whether it's a basic contact lens exam, this is what I'm looking for. I'm looking for damage from the contact lens. I'm looking for oxygen starvation. I'm, looking for this. I'm looking for that. They understand what you're doing. They have more value in what that does, and they're willing to pay that little extra money to get the Optomap or an imaging done.
And I think you hit the nail right on the head because in today's environment, patients are looking for value.
Mm-hmm.
And value could be, I think some of us are feeling it in our optical by saying, hey, we're seeing fewer dollars being left at our optical or patients pulling out their credit card and not being as excited to hand it over for larger amounts.
Sure.
And so we're seeing the number of dollars being spent go down, but we are seeing the number of exams go up.
Right.
And so creating value during that exam could naturally translate, and I'm going to something like, and I'm going to take this doctor's recommendations, whether it's in the optical or whether it's with a different treatment plan. But to your point, them understanding that they're getting value out of that exam, it requires you, the provider, to be able to communicate that value. And it's not just, I've seen this happen so many times, and I've gone in for secret shopper exam type of things where I go in and it's okay, so this is a picture of the back of your eye and everything looks good.
Yes.
And that's what that's what I hear. And you're like, man, like compare that to what you just said, Sage. I feel that the patient would understand the value, infinitely more out of a conversation like that, when you get a chance to invite them into your thinking process as you're going through the exam.
Right. And I think that's what every piece of tool should be. Every tool is that exactly what it's a tool, and it's for patient care. If they don't understand why they're doing it, why are we doing it ourselves? So
Yeah.
so I think that's
and so
basic.
we should link every tool
Everybody's got
to
some kind of fundus camera, right?
Mm-hmm.
Have you been in any offices recently that don't have some kind of fundus camera?
I don't think so.
No, that's basic, and we've all made that work, correct?
Mm-hmm.
So other technology. I do treat a lot of glaucoma. We talked about that. I think it's indispensable to have OCT, ocular coherence topography. Again, we started with our original HRT, Heidelberg Retinal Topographer, way back in 2001. After that kind of technology wasn't kind of where we needed it. We wanted to do more retinal things. We see a lot of patients with macular degeneration and cystoid macular edema, things like that. We got our first Stratus, Zeiss Stratus, and I bought that used. We couldn't kind of justify the full price of that. How often are we going to be able to use that? Because you can't do that on every patient. There's going to be a very select patients that you can do that on. So finding a used piece of equipment was great. And I look back at the images of that and, oh my gosh, they were terrible compared to what we have now, but they were so good at the time. When you had a patient, you just kind of didn't know why a patient wasn't seeing well, and you put them on the Stratus, and they had a vitreomacular traction that you could look at, and you go back and you look in the eye and you go, geez, I just can't see that. And so having that technology when a patient comes in, is like they're not seeing well, and you can't figure out why they're not seeing well. You have to have something that can do that. So, like I said, we bought our first one used. Literally bought it for about $20,000. On that time they were $120,000. For a brand new one. We got it from an ophthalmology group that had moved up to a Cirrus, so we got the Stratus. I used that for about 5 years. Ended up selling it to a friend of mine who had no imaging device. So sold it to a friend, so she had something that she could use. As we moved up the ladder, we moved up to a Optos. At the time, bought a company that had OCTs. We got that. It was so much better technology than the Stratus, but it still pales in comparison to what we have now. You've heard me talk before. I'll make my confession here. I am a brand ambassador for Visionix, their Solix OCT. Probably the best thing I've ever had in my office. It's like taking that old 1 megapixel camera and now having 1,000 megapixel resolution. Everything you can see in there. I had a patient last week came in and he came in and said, I'm just not seeing well in my left eye. It seems like there's this fuzzy area kind of near the center. And I'm thinking, he's probably got a PVD and a floater in there, something in the way. And I look and there's just nothing. I cannot see anything wrong with it. Try to take a little beam slit to look through the back. I said, let's just pop him on an OCT. Sure enough, he's got a nice central cirrus, not real elevated high, but an RPE detachment. It's in there. And showing him that, pulling it up right in front and say, this is why you're not seeing well. Look at this. Here's your right eye that looks perfect. Here's your left eye. This is what it looks like. They go, oh, wow, that just does not look the same. And so having that kind of technology is just revolutionized how we treat things. Because now I know, hey, there's no blood underneath there. We know I said, look, this usually comes on when you're stressed. He said, this is the most stressful time I've ever had in my life. I said, okay, so you need to find to get rid of that stress. And if it doesn't go down, we have to look at some treatment options. But most of the times he's resolved. Let's do it again in a month and see what it looks like. And of course, he wants to come back, wants that done again. And make sure, because he knows what's going on in there now. So he's comfortable going, okay, I can live with a little bit of blur. I know what's going on, and I'm not stressed about it anymore. And that's stressful. All of a sudden, you can't see out of one eye very well. And it was great to have that technology. So, I think most offices don't have an OCT unless they're really treating a lot of glaucoma or retinal diseases. But again, how can you make that affordable? A new OCT is going to be $80,000 to $100,000. Again, maybe you find a used one, but we go through the same numbers. Let's say you get an $80,000 OCT. That's going to cost you $1,500 a month with a loan. Okay. You're going to get paid about $38 with Medicare. Okay. Or Blue Cross or Blue Shield, which means you got to see about, there's your 10 patients a month that you have to see, right? To make this thing pay off. So 10 patients a month, you have to do some kind of OCT. Now, if you're in an area that, has a big HMO and a patient comes in and you say, gosh, this is just not making sense. There's something going on here. We have a couple options. I've got the instrument right in the room next door. You can private pay for this, $50, $40, whatever you want to charge the patient. Or I can send you into Kaiser and you'll get in there in the next, I don't know, a couple weeks or months, or I don't know how long they're backed up in there. And they can figure out what's kind of going on. Now, what patient wouldn't pay $40 to figure out what's going on with their vision? And so I think the one thing we always worry about is, oh, I'm not a provider for their insurance, so I have to send them someplace. Well, why? I've got the technology right here. I can find out right now within 5 minutes what's going on in the back of your eye while you're not seeing. And it'll only cost you $40 as a private pay or $50, whatever you want to kind of do on that. And so could you have 10 patients in a month that you can do that? Yeah. Okay. Whether they have insurance that you can use or whether they don't have insurance you can use. You can do that. Back in the olden days, I had friends of mine who, 3 or 4 of them would go together and buy one OCT and would travel around from office to office. And they'd have it for a week, and then 3 weeks later, they have it again. So they schedule all their glaucoma patients during that week and use that. Now it only costs you a third amount of the money to do that. There are ways to do this.
So I know you do a lot of glaucoma, but what percentage of a typical, like if someone sees 12 patients a day, 15 patients a day, what percentage do you think are good candidates for an OCT?
Well, you know what? That's exactly right. Somebody who says, somebody who has, who's obviously a suspect for glaucoma would be a good one. There's been a lot of studies that amlodipine damages the ganglion cell complex and increases glaucoma progression in patients who have no other symptoms or no other reason to have glaucoma. How many of our patients are taking amlodipine for high blood pressure? You say, geez, you're on this medication that I think I looked it up, is 40% higher risk of developing damage to your ganglion cell complex. You say, gosh, you know what? You're on a high risk medication. We should do this imaging so we have a baseline. And even if we do that every 2 years to look for any damage on there, we'll know if amlodipine is going to do some damage. And why'd you wait 2 years? Hey, you're on a medication that can cause you to lose your vision, make you go blind. So let's do a scan. You're on Plaquenil looking for toxicity. You're on amlodipine. You're on all these methotrexates. There's a lot of medications out there patients are taking that have lots of very significant retinal toxicities that kind of make sense to do some baseline screenings and do those things yearly. So those are great candidates for an OCT. A patient who says, gosh, my mom's going blind my mom's getting these shots in her eye. They don't know what it's for usually. My mom's getting shots in her eyes. Well, yeah, that's macular degeneration. Oh yeah, that's what he said. She's got macular degeneration. So should we catch this way before you have any problems with that? Yeah. How can we do that? We have an instrument that can do that. That can take scans, take 1,000 slices through the back of the eye. It's like an MRI. Essentially, it's an MRI, 1,000 slices in the back of the eye that builds a three-dimensional topographical thickness map of the back of the eye. Why wouldn't I want that for $40 or $50? So patients that are at risk, family history, they always say, gosh, I did that 23andMe and it says that I've got 4 risk factors for macular degeneration. Well, we should start doing this scan. Look for that. And so who else would be a good candidate? You name them.
Yeah. Well, and I think you bring up a really good point, is that it is interesting to think about the number of patients where it's absolutely medically necessary.
Right.
And maybe that pool is a little bit wider or a little bit deeper than we necessarily always think. And you're absolutely right. If somebody is on blood pressure medication, I mean, almost instantly you're arguing, hey, you gotta get them in. You gotta put them. You gotta get an OCT done.
Right. And so I think that's an important thing. You can tell the patients, look, you pull up a study right there in front of them and say, look, here's what it says: 40% higher risk of losing vision from loss of ganglion cell complex. And if you start having that, we're going to catch it before you go blind, get you off that medication and on something different.
And do you bill for that medically?
Yes. Oh, certainly.
Yep.
Certainly. Again, if they have an HMO or something that you can't, then you ask them, hey, would you like to do this? It just makes sense to do this kind of testing. So I
Mm-hmm.
can bill that medically on a lot of my patients, but there are patients, there's a few that have HMOs that I can't do that.
Got it. Makes perfect sense. I think that's great, Sage. And when we come back, I'm going to ask you a little bit more about other glaucoma treatments and other technology that you have in the office. I think there's an interesting conversation as we think about how you make sure that everything in your office is earning money for you, and that it's not just, and like you said, kind of the criteria for bringing technology into the office is not just about the economics, but the economics are pretty important. We'll be right back.
Hi, this is Allie at the Power Practice. Every month when we talk to clients, staffing comes up as one of the biggest challenges. Finding the right people, avoiding costly hiring mistakes, and trying to build a team that actually sticks around. It can feel like an uphill battle, right? What if you could finally take the guesswork out of hiring? That's why we're so excited to bring you Hire Smart by Wonderlic and the Power Practice, a hiring solution designed specifically for eye care practices. Here's the game changer. Hire Smart doesn't just measure cognitive ability, problem-solving skills, and learning speed. It also gives you exclusive insights into a candidate's work style, adaptability, and even how they'll fit into your practice culture. Imagine making a confident, informed decision before you even make the hire. And the best part, we've made it affordable and easy to use so you can start building your dream team right away. If staffing has been stressing you out, it's time to turn things around. Visit thepowerpractice.com and click on Hire Smart to get started. Let's help you hire smarter and stress less.
Hi, welcome back to the Power Hour. I'm here with Dr. Sage Hyder, and I am really enjoying this conversation. And one of the reasons why is because you've got such an unassuming attitude about the patients that you treat and how much you care about making sure that they're fully educated. But the other part of it is that you got this almost like I highly disciplined, meticulous attitude about making sure that this technology is like another associate just earning money for you in the office. So let's go through. I know I want to make sure we cover some of the big ones. So what other technology have we not talked about that we need to when it comes to generating revenue and doing so in a smart way for your office?
Great. Well, I think we kind of hit the big ones. The big ones I always think about some kind of retinal imaging, some kind of fundus photo, some kind of OCT. You need that in there. But then the third one, very important one that we all have, some type of technology, is some type of visual field analyzer. We have these big giant ones that sit in our exam rooms or sit in our testing rooms that patients have to pull themselves up to. Sometimes they're difficult. People in wheelchairs, older patients, younger patients sometimes are not real accurate on them. I've recently incorporated in my practice a virtual reality headset. There's a company that I also work with, Micromedical Devices. I became first introduced to them years ago when I needed a pachymeter. And my pachymeter I bought, I have a PacMate, or it's a palm scan pachymeter. It's fantastic, nice, easy to use. Takes 25 very, very quick in measurements, averages very, very accurately. One of my favorite little tools that just did not cost a whole bunch. We need those, obviously, in glaucoma treatment to know what their corneal thickness is. But a visual field instrument, they came out a couple of years ago with the VF2000. It's a virtual headset. Patients literally just strap it on. They've got a little button in their hand. Has been a really great addition to my practice. It's one of those instruments that, again, gives a wow factor to the patients. They put it on and go, wow, look what Dr. Hyder's using. He's using like modern technology instead of put me in that big clunky thing that I hear goes zzz, zzz, zzz. So I'm just going to push the button whenever I hear that thing move. And you get these crappy visual fields because they're not paying attention. They fall asleep in them. They take too long. I'm just pushing it every time I hear it move because I think there's going to be a light right there.
My favorite is that the staff forget to turn off the light. You know how many times I've seen that?
Yes, exactly right. You got all this reflection coming from behind you. They get distracted by the movement on there. So I incorporated the VF2000, a great instrument. That's about a third the price of a full-size visual field machine. And so it's great. You can do it in the exam room. So my staff takes the patient into the exam room, checks their vacuities, checks their pressures, said, hey, we're going to do this test, to pop it on right in the exam room. So you don't need an extra testing room for it. Or it frees up the testing room for somebody who's getting an OCT or doing something else. They have all the standard and more visual fields, whether it's photosis, whether you want a neurological 30-2 type of style or 24-2 type of style, central 10 degrees, and they're really kind of a neat tool. So I thought, gosh, my older patients probably wouldn't go for this. They're probably going to be, oh, this technology, I don't want to kind of do that. I asked every patient, hey, how was that? Was that difficult to use? Oh, no, gosh, that thing was so easy to use. So remember I said earlier, the technology has to be easy to use. My staff, it has to be easy for use, and the patients have to be easy for use. One thing I really, really love about the VF2000 is the eye tracking ability. You look off center a little bit, it pauses. As soon as you refocus, it keeps going. You look off center, it pauses. You look forward. The tests are highly, highly reliable. You just don't see a lot of false pauses, a lot of false negatives. You don't see fixation losses because it eliminates all that to get you a very, very clean test. And so having a test that's repeatable, that the patient can do well. Subjective testing are terrible. We've done this for years looking at, did you get a trial lens in the way and there's a big defect there? Did the patient just fall asleep and the whole upper lid's droop down and you can't see anything up in there, trying to do a glaucoma test on that? So, again, this is like a third of the price of a big standard type of analyzer.
Well, and how do you bill for it?
How do you bill for it? What can't you?
Let's do your math.
Okay, let's do the math. So I looked this up. The payment that I was making on this is $199 a month.
Okay.
Okay, so we're not even in the realm of the equipment we've been talking about. So $199 a month. Again, $40 is what you're going to get paid by most insurances. That means you need 5 patients a month to pay for this thing. 5 patients a month, okay? And so versus 50 patients a month for the other things we're looking at. If you have a visual field analyzer or something like that, that's going to cost you $50,000. You need 25 patients a month to be able to do that. And most people don't have 25 glaucoma patients or neurological patients or ptosis they're going to be referring for. I don't think most people are doing that, especially in the cities where you have big HMOs and stuff. So 5 patients a month. Again, if they've got an HMO, you say, gosh, you know what? We can do it right here in the office. There's 2 testing we need to do to treat your glaucoma. We need to do the OCT. It's going to cost you $40 to $50. We're going to do a visual field. It's going to cost you $40 to $50. You're going to charge the patient $100 to get your glaucoma managed right here in my office right now. Or we can send you off and you don't know who you're going to see every time. It's going to be a different doctor, and it's going to take 3 months to get in to do that. Okay. Mm-hmm. So, again, if they've got private pay, offer them to private pay, a reasonable price. For great technology. So, who else are you going to use that for? You're going to use that for your Plaquenil patients again, right? Because your Plaquenil patients need a 10-2, a baseline. And then after 5 years, they need to have that yearly, and so you're using that on any of your Plaquenil patients, your hydrochloroquine that you're taking on that for their lupus and their rheumatoid arthritis. I mean, I see a lot of patients on those types of medications. So you're going to do your 10-2 visual field. You're going to do an OCT. You're going to do an autofluorescent imaging with your imaging device, your camera. That's a standard protocol for somebody who's on Plaquenil.
And how many glaucoma patients are you seeing on a monthly basis?
A typical day I'm seeing probably 3 to 4, whether they're suspects or they're treated. So in a month I'm seeing probably more than that. Yeah, okay. So let's say 4. I see 4 a day, 3 to 4 a day, and for 16 days a month, there you go. So I'm seeing 50 to 60 patients, probably around 50 glaucoma patients a month. So,
okay.
And then I have 2 partners that are probably doing about the same thing. So I'm lucky being in a partnership. We can kind of take a piece of equipment like that, and it's just not all on me. But I've made you see how it works with just one doctor. Mm-hmm. So if you have one doctor paying for an OCT, needing 10 patients a month to pay for it, you have 3 doctors in a practice or 2 doctors in practice. That really makes that a lot more a reasonable type of thing. So
yeah, and with this, I just did your numbers. So you've got if you're saying you got 50 glaucoma patients or suspects or whatever that you're running a visual field on, and your reimbursements on average $40, and you're talking about $2,000 that you just brought in revenue, and you spent $199 in cost to do that. That's pretty good ROI.
I think you figured that one out. That's exactly right. So let's say you're seeing half that many patients, or even a third that many patients. You're still going to pay for this thing. It's ease of use, great data, and cost effective that you can have it in your practice. Anybody can have that in their practice. And so,
that makes perfect sense. I love it. What else? And in terms of other technology, whether it's must have or nice to have, what else ROIs nicely in your practice?
Well, I think those are the must haves that you kind of have to have in there. I think a really great, we were just talking about on break, is anterior segment camera. Anterior segment camera, like I said, I was at a billing seminar years ago, and the speaker said, wow, this is one of those things that Medicare has not dropped the reimbursement on a whole bunch because it does not get billed a lot. They're very inexpensive. Nowadays, you can essentially get a mount for a camera from your phone that you can mount on a slit lamp ocular and take a photo. And they're very, very easy to use. They're impressive to patients. You can download it right into your EHR. So that for the price of a mounting device in your own cell phone, that's a great thing. So somebody's got a lesion that you kind of go, well, that's a little suspicious. It's, maybe changing. You ask the patient, gosh, did that change? I don't know. I think it's changed a little bit. You take your baseline photo. You do that once a year. You can actually even use that for a fundus camera. Because if you can focus your slit lamp through the ocular into the retina, you can take a photo. So you can bill it as a fundus photo. You can bill it as an anterior segment photo. Those are great instruments. So an anterior segment camera is a really inexpensive way to go to be a good profit on that.
Well, I think you're absolutely right. From a technology standpoint, it's something that impresses patients. And I also think from a case acceptance or treatment plan acceptance standpoint, it helps with certain subspecialties, right?
Yes. Yeah. We talked about dry eyes a little bit. If you have an anterior segment camera and you can express the meibomian gland so the patients can see what's kind of coming out of those, you show them and they go, wow, that's not good, is that? Well, no, here's why we have to do these treatments. And whether that treatment is doing some laser treatment or whether that's doing just, something else, they understand that there's something wrong there and they're willing to do treatments for that. So even though you can't really bill for that, you're doing that in order to present other treatments on that, So I don't think you can really bill a fundus photo for meibomianitis, but you can do it for obviously lesions on the lids and things like that. So corneal foreign body, you take a photo of a foreign body before you remove it to prove that it's there. That's actually billable. I don't typically do that, but especially if it's...
Well, I was going to say, that seems like Friday foreign body removal.
I should be doing that every Friday.
Yeah, let's bump your reimbursement by $40 every time.
Yep, exactly right. Well, there's another one, gonioscopy. I found myself not doing gonioscopy for about 10 years, and I thought, why am I not doing this on every one of these patients as a glaucoma suspect? And you do those annually. There's an extra, Medicare pays you an extra $12, but it takes you how much time? And everybody's got a gonioscopy lens in there because we had to buy them in school. So we have that. Other technology, I think, the needs and the wants. We talked about pachymetry. You have to have a pachymeter if you're going to do any kind of checking somebody for glaucoma because you have to know what their central corneal thickness is. Corneal topography, I think, is a great one. I don't think that's a need. It is a want. The patients that you're just not clearing up well, they're young, there's no retinal diseases. Is there, a change in their sill, or do they have keratoconus? You kind of need to do that, though most of the OCTs now can do that with corneal mapping and corneal thickness. So a corneal thickness map of with an OCT can actually show you corneal thinning and show early signs of keratoconus. So there's another reason you can use that OCT and get that to pay off. But a corneal topography is great. You have irregular astigmatism, if there's some, cones starting to form in there. If you're fitting specialty lenses, you kind of need one of those. You can't really get it paid for that, unless they do have something irregular that you can bill it for. But if they're a high myope and you're doing scleral lenses, they have a lot of sill, you can't get paid for it, but you kind of need it. So that's an instrument you might buy that won't necessarily pay for itself by doing the imaging, but will pay for itself by doing the treatments.
Right, by enabling the treatment plan. Exactly.
And then you can show it to a patient and say, look, this is why we're going to do this treatment plan. And so that would be one. I have friends that are doing a lot of EOGs, and EOGs have been really, electrooculograms have been shown to be very successful, very important in glaucoma, showing that there actually is nerve damage going from the eye to the brain. So the optic nerve gets damaged. You can show that on EOGs. I haven't quite incorporated that in my practice. I've been thinking about it, talking to some friends who are utilizing it. It's another tool. I'm just trying to think if that would actually make better patient care versus just something I'm going to bill. And so I have to justify that in my mind that it's going to give me better patient care.
Mm-hmm.
So there's things like that. What other instruments do you see being used that kind of once?
Well, and I think one of the things that we should probably wrap up with as you're kind of thinking through this is just one more time. Let's go through the criteria.
Okay.
Is there a particular number of dollars from an ROI standpoint? And then you talked about ease of use for staff, ease of use for yourself, and ease of use for your patients, right?
Yeah.
What are the things that you've said no to over the years? Or what are some things you've tried and you're like, this was a mistake. Ship it back, baby. Or maybe, like everybody's got a closet full of old technology that,
right.
And maybe you don't because you take such a meticulous approach to acquiring it. But what if you had a closet, what would be sitting in it?
Actually, I have a 2001 HRT sitting in my room that I just finally decided I'm just actually going to take it to the dump. Nobody wants this thing, and we haven't utilized it in about 7-8 years, and it's kind of taking up space. And but that was a great technology at the time. Again, passing things on to other people. If I had my original Stratus that I sold to a friend, got a great deal. I think I bought it for $20,000, and she bought it for me for about $6,000. And but I got definitely my money's worth out of that. There's not a lot of technology that I just haven't been happy with and sent back. But I did at one time have 4 different OCTs in my office, trying them all. And so when I decided to buy the Solix, I had 4 different instruments in the office at the same time, and it was mostly about staff was having difficulty getting images, patients couldn't get a good image. My criteria were ease of use. I needed a ganglion cell complex thickness map. That was kind of the one that I thought needed to be done. The old instruments didn't have that. And then repeatability. And the last one was normative data. You have to have normative data in an instrument that shows what age gender normal should be and where your patient is outlying that or within the normal range of those things. And so I think those are important instruments to look at. So a criteria would be, hey, how does this compare to everybody else? How does it compare for that patient over time? So the repeatability on that. The cost, is it going to be feasible to do that? I don't think I've ever sent an instrument back that I didn't like. I didn't buy it because I didn't think I needed it. And so, like I said, at this point, I think, looking at optometry and practicing in a modern setting, in a modern, scope of practice, we all need a camera. We all need an OCT. We all need a very good visual field analyzer. We all need a pachymeter. An anterior segment camera would be a really good want. But you have to see if that's going to be feasible in your practice. Corneal topographer, depending on what you're doing. There's a lot of tear film analyzers. And again, if you have a practice that's going to do a lot of dry eye, you need a tear film analyzer. And I think that's probably the next instrument that I might be looking at, some kind of laser to be doing treatments for dry eyes. I think would be very, very beneficial. Unfortunately, there's a practice around my area that got one, and I've had several referrals from that. Not referrals, I've had several patients come from that office to see me because they felt like they were being pushed into getting a treatment that wasn't justified and cost too much. So I think if you're going to do that, if you're going to do a dry eye clinic, that you have to have some kind of imaging device that says, look, this is where you're dry. Here's what your tear film looks like. Here's your meibomian glands. Here's what's going on. And so this treatment's been shown to fix that problem. Now, that would justify it to a patient's mind that they're going to spend $1,000 to have 3 treatments over, the next, 2 months, and justify that. And so again, that would be an instrument that you probably couldn't bill for, but it would drive the treatment plan that you would then be billing for. And that would be something that would be most of the cases a private pay type of situation. So,
and Sage, I think, and I think we can end on this, is that no matter what instrument you get, you'll be more successful with it if you can take the Sage Hyder approach of, let's actually talk to the patient and explain and educate all the details, rather than just taking the image or utilizing the instrument and saying, okay, everything looks good, and kind of moving on.
Yeah.
So I think it's not just about the technology. It's about how you use the technology to drive return on investment. But in addition to that, how you use the technology to add to the wow factor in your practice, to increase patient loyalty, get your patients to come back more often, and probably refer others because they're so dang impressed with not just the tech that you used, but what you explained to them after you use that technology.
Right. You look at a phoropter, and a phoropter has not changed in, 100 years. We have some electronic ones, they're fancy. I don't know if patients get a lot out of that, but you see the other stuff, that's what you're here for. Refraction is refraction, but teaching somebody about the health of their eye. I said earlier that I thought my patients were intelligent enough to understand what I tell them. I think that's mostly true, but the second half of that philosophy is my patients, they're the only ones in charge of their own healthcare. So if you don't give them the correct information, they can't take care of them.
Well said. Dr. Sage Hyder, thank you so much for joining me on the Power Hour today. It's been great having you on the show. Thanks for listening to today's Power Hour episode. The Power Hour is actually owned by the Power Practice. Power Practice is a premier consulting group who helps practices achieve freedom of time, confidently solve practice issues, and grow their practices. They do this by having coaches and OD consultants, people who have actually done it, been there, and they're ready to help. If you want to learn more, go to powerpractice.com. There's a bunch of free tools there. You can also get a whole bunch of information and decide whether it's right for your practice. Again, if you're looking for more time, you're looking to solve complex practice issues or grow, the Power Practice might be right for you. Go to powerpractice.com to find out more.